Next bacteria, CORYNEBACTERIUM diphtheriae. I know, pretty super long name over here, huh? So let's talk about some characteristics of CORYNEBACTERIUM diphtheriae. So another time, we have another gram-positive rod, one of many, with an exotoxin encoded by a lysogenic prophage. What is a lysogenic prophage? So that means that you have a prophage, which is a virus that infects bacteria, incorporates into the DNA of the bacteria, and carries with it some genes from previous bacteria, allowing for it to produce the exotoxin. So toxin inhibits protein synthesis by ADP ribosylation of EEF2. So ADP ribosylation of eukaryotic elongation factor 2. If you inhibit that in eukaryotes, you cannot undergo translation, so that causes lots of cell death. It's a common asymptomatic colonizer of skin and upper respiratory tract. That's why it can cause infection. And symptoms. What kind of symptoms happen with this disease? It can get pretty bad. It can start with an exudative pharyngitis, which is similar to EBV and group A strep, but this can get really, really bad and lead to thick pseudomembranes, which are grayish-white colored, in the oral cavity, made of bacteria, lymphocytes, dead cells, and fibrin. So this exudative pharyngitis can get worse and lead to this thick pseudomembrane, which you see here, and that forms in the oral cavity, and it's full of dead cells, lymphocytes, fibrin, so it's a really thick, stuck-on appearance. And it can extend all the way into the larynx or even the nasopharynx. So it can go into the back of the throat, or it can even go down into the oral cavity, the vocal cords, into the larynx. And the pseudomembrane is basically stuck on and attached to the mucosa, so it will bleed if you try to poke at it or manipulate it. It's also associated with lymphadenopathy, and that gives you a bull neck appearance. You get a very thick neck with this disease. Another thing that can happen with CORYNEBACTERIUM diphtheriae, which we'll talk about more in the next slide, is myocarditis. Usually presents about 1 to 2 weeks after the onset of symptoms. So as the pharyngeal symptoms are improving, that's when the myocarditis strikes and gets pretty bad. So always remember, the pharyngeal symptoms start going down, that's when the heart symptoms start to appear with CORYNEBACTERIUM. How are we going to diagnose this condition? Remember, the toxin is its key feature. So you get a positive toxin PCR assay. You can also culture the respiratory secretions to grow some CORYNEBACTERIUM diphtheriae. And how are we going to treat it? Diphtheria antitoxin. So if you have a major toxin, we can give an antitoxin that neutralizes it and stops the cell death and the problems associated. And you can also give penicillin G or erythromycin because you want to stop the toxin from being produced by the bacteria as well as get rid of the toxin itself. So the antitoxin gets rid of the toxin, and penicillin G and erythromycin kill the bacteria producing the toxin. Now let's talk about vaccination. Remember, we have to go over all the vaccines because that's really highly testable on Step 2 CK and Step 3. So we have 6 total doses given to children. You do not have to memorize these, but know that CORYNEBACTERIUM diphtheriae toxin, or TDAP or TD, is given to kids when they're young. And it's also given as a booster vaccination every 10 years after the age of 18. So after 18 years old, you should get a DTaP every 10 years to boost the immune system and keep that vaccination strong so you don't get Clostridium diphtheriae in the future. So we give close contact prophylaxis as well. So if somebody in the family has a documented case of diphtheria, you need to give some prophylaxis for it. So you collect the nasopharyngeal specimens so you can grow them and see if a patient has CORYNEBACTERIUM diphtheriae, and start prophylaxis on all these patients. And if the pharyngeal secretions come back negative, you can stop the prophylaxis. So you collect the secretions and culture them, start everyone on prophylaxis, and only stop the prophylaxis if these cultures are negative. And remember, for this booster vaccination after 18 years old, you get it every 10 years to boost the immune system and prevent diphtheria. So also prophylaxis with vaccine if you have incomplete diphtheria immunization history. So say that they have a close contact. You always should give prophylaxis if they have incomplete diphtheria immunization. Major indicator. And if they have no booster dose in the last 5 years, they also need prophylaxis with the vaccine. Okay? So if they have complete vaccination history, you just need to culture and treat with antibiotics. If they don't have good vaccine history, they need to be vaccinated on top of being given the antibiotics. So you have incomplete diphtheria history, you don't get all the diphtheria shots you're supposed to, and no booster dose in the past 5 years. Very important stuff to know. Now let's talk about myocarditis. So it's in the name, myocarditis. So itis means inflammation, card is the heart, myo is the muscle. So inflammation of heart muscle. Most common cause is Coxsackie B virus. Alright, so you always want to remember that this is the major cause that you will always suspect, and it's one of the enteroviruses. Other high-yield causes are diphtheria, Chagas disease. So these are 2 other causes. We talked about diphtheria, and Chagas disease caused by Trypanosoma cruzi can also cause it. And we'll talk about that in a later slide in the future. Presentation of this disease. You start with viral URI symptoms. Alright, it starts out as a common cold, but then rapidly progresses to cardiogenic shock, heart failure, chest pain, and even arrhythmias. This can be pretty fatal in patients and should be treated accordingly and managed accordingly. It causes a dilated cardiomyopathy because what happens if the muscles are inflamed and damaged and they can't pump? They're going to get filled with blood and dilate. So when you damage the heart muscle, you decrease contractility and decrease systolic function, so you'll dilate and you'll have a systolic failure, dilated cardiomyopathy. You can also get pulmonary congestion, dyspnea, Rayleigh pulmonary edema due to fluid in the lungs, and that's all due to left heart failure. So what kind of physical exam findings are we going to find? We get an S3 heart sound. Why do we get an S3 heart sound? Remember, an S3 heart sound is an indication of fluid overload. That means you have way too much blood in your left atrium, and when the atrial blood goes to the left ventricle, which also has too much blood, you hear a splashing sound. That's the S3. It's lub dub dub, da da da, da da da. If you hear it on auscultation, it'll be like a horse galloping, but it'll be da da da, da da da. You'll hear that when you see it. Function of regurgitation murmurs. Why do you get these? Remember, if you dilate a ventricle, what's going to happen? You're going to stretch on the valves as well. If you stretch on the valves, you open up the valves during systole, and you get backward flow through the mitral valve. So you get a functional mitral regurgitation with left ventricular dilation. So how are you going to diagnose this condition? We're going to diagnose it with EKG. So it's going to have arrhythmias and signs of myocardial injury. So arrhythmias such as VTAC, VFib, things can all happen because of damage to the heart tissue and the electrical fibers in the heart tissue, or signs of myocardial injury. And what are some signs of myocardial injury? These signs are T-wave inversions, ST elevations, ST depressions, Q waves. Those will all tell you the myocardium is damaged and can help lead towards a diagnosis of myocarditis. You also get cardiac biomarkers. Remember, the muscle is getting damaged. So you have increased troponin, increased CKMB, and chest X-ray will show enlarged heart, pulmonary congestion, and increased vascular markings. So because of this failure and the excess of blood causing dilated cardiomyopathy, you get cardiomegaly, and because of backup of blood, you get increased vascular markings and pulmonary edema on the chest X-ray. Echocardiography is a definitive diagnosis. So how are we going to treat this condition? Supportive care for heart failure symptoms. Remember, this cannot really be cured. It's a viral infection, so you have to support them until the heart is able to recover, and then the dilated cardiomyopathy goes away. So this is a temporary condition. To give supportive care for heart failure symptoms, these include diuretics and oxygen if needed, and also avoid beta blockers acutely. Remember, this patient's in acute contractile heart failure. They can't go through systole. What are beta blockers going to do? Make systole weaker. Would that help? Absolutely not. It would make it worse. And also an ACE inhibitor to prevent remodeling. What does remodeling mean, and how do ACE inhibitors prevent this? Remodeling means that the heart changes from its normal shape to a more dilated shape or more hypertrophied shape. And the way an ACE inhibitor prevents this is by decreasing the preload coming back to the heart by inhibiting aldosterone. And by decreasing preload, you can help decrease the dilation of the heart. Now we have a question to go through. Let's try this question. Which of the following is the most likely finding seen on echocardiography? So we need to see what is seen on echo. Hypertrophy of the left ventricle is A. B. Pericardial thickening. C. Pericardial fluid accumulation. Dilated ventricles, low ejection fraction, or normal findings. So, a 21-year-old man presents to the emergency department with acute shortness of breath, chest pain, and fever. So he has shortness of breath, so dyspnea. He also has chest pain, and he also has fever. He had a viral URI for a few days with nonspecific symptoms such as rhinorrhea, cough, and conjunctivitis. So preceding this shortness of breath and chest pain, he had a viral URI. However, he suddenly worsened and started having severe chest pain without exertion and dyspnea at rest. He's never had symptoms like this before and has no history of previous illnesses. The attending physician suspects that the patient has acute myocarditis and orders an echocardiogram. What is most likely seen on echo? Remember, we talked about this. What is myocarditis? It's damage to the heart muscle. And what is heart muscle supposed to do? Contract. So if the heart muscle can't contract, we have severe problems here. And what's that going to cause? Systolic failure. Will you get an enlarged left ventricle when the ventricle is inflamed and damaged and can't pump? No, it will be smaller and more dilated and full of blood. Hypertrophy is the opposite. Pericardial thickening. This is myocarditis, not pericarditis. There won't be any pericardial thickening. Is there any sign of tamponade? No, if a patient has tamponade, they're not likely to have too much chest pain. They're more likely to have hypotension, and also they won't have too many lung findings and shortness of breath. they'll more likely have decreased forward flow. And there's no indication that this patient has pericardial fluid accumulation, and myocarditis is affecting the muscle of the heart, not the pericardium. Dilated ventricles with low ejection fraction or normal findings. Are they going to have normal findings when they're this severe? Absolutely not. You're going to have a dilated ventricle with low ejection fraction because this is a dilated cardiomyopathy causing a systolic failure.